let me try to run through these slides a little bit. Okay. The next portion of the central nervous system discussion is on the cerebrum. The cerebrum is, of course, is the main processing area of the brain where you analyze information. We talked about before in the last hour. It breaks it up into sensory information coming in, and then it decides in the frontal lobe as to what to do. We basically have two individual cerebral hemispheres, and depending on if you're left-handed or right-handed, or and many different factors, the hemispheres actually have different abilities to do things. Okay? The connection of these two hemispheres is what actually can give you information about what you're holding on in one hand and then describing it verbally in the other hemisphere. We know that to be the case because we've actually seen patients that have had injury. I had one lady who actually got a machete injury to her head. It literally cut her corpus callosum, which is a connection between the two hemispheres, and she actually survived the event. She went home actually about 2 weeks later. And when she came back in for evaluation, when we put things in her hand, and she knew she had something in her hand, but she could not tell us what it was, but she could write it down. It's really strange. She couldn't say what it was, but she could write it down. So depending on which portion, the hemisphere that you put it in which hand, you get a different response. So very interesting how the brain has to be connected. But when she had her eyes open, almost all that impairment went away. So really, as to actually affecting her life, it affected it very little, even though she had significant injury to the brain. The two cerebral hemispheres are broken down into two major components called the gray matter and the white matter. The gray matter is on the outside of the brain because that's the area where the nerve bodies are located at. That's where they actually receive, integrate, and store and transmit information. It's the cell bodies and dendrites. Okay? The white matter, on the other hand, is the myelinated fibers that are leaving as axons from these nerve bodies. Okay? And that's on the inner portion of the brain. Okay? So the gray matter is actually on the outside, and the white matter is on the inside. Okay? The cerebral hemispheres can be classified as lobes. Okay? The frontal lobe can be considered where we actually do everything that controls us in the sense of emotional control of the prefrontal cortex. Then you have the precentral gyrus, okay, which is the homunculus, which is actually the layout of the body on it. Okay? The actual layout of the body is basically like somebody laying down over the hemisphere with the leg as an inside in between the hemispheres, and then the face being all the way at the bottom with the arm being in between. And I'll show you a picture of that in a minute. This is a precentral gyrus right here, when I'm showing you right here. That's the actual motor strip that controls your legs, face, and your arms. Okay? You also have an area, it's called the inferior frontal area. It's called Broca's area, which is the talking area. Okay, that's what actually allows your mouth to open properly and your larynx to work properly. So if you have damage to the Broca's areas, then you lose the motor ability. So you'll understand everything that's being said to you because you still have the integration of the temporal lobes, but you can't talk back. Okay? This is a nice picture showing you how the brain can be separated out into different components anteriorly and showing you the different components of it. Now, again, frontal lobe. Okay, this is the central sulcus, which separates out the frontal from the parietal lobe. Okay, the motor tracts are in the frontal lobe, and the right immediately posterior, what's called the postcentral gyri, okay, is the sensory strip. Okay, and it's laid out in a very similar homunculus fashion, which I'll show you that in a second. Okay. You have the temporal lobe down here, which is responsible for auditory control mechanisms. You have Brodmann's area, which is a different way of identifying location, called Brodmann's area 44, 45. All these are different areas that control different things based on certain kinds of clinical findings that you see in patients. Okay. And then you have the visual fields, which is posteriorly. And this is a homunculus layout. This is how the actual brain is laid out internally. Okay. This right here is the medial portion of the brain. This is where the middle portion, this is where the corpus callosum is out down here, which allows the integration between one hemisphere to the other. Okay, so this is one hemisphere only that you're seeing on this drawing. Okay, this is the actual sensory component. is on the, which one's the sensory? Okay. Sensory strip is here, the top one here. Okay. You can see that the layout shows you that the sensory information is much higher in density in the lips, okay, and in the thumb. Okay, so you have a lot of receptors at your thumb and in the forefinger, the two forefingers. Okay, and you can see the body's laid out on the top and the legs over the side. So different portions of this actual strip is the actual information coming in from different portions of the body, which then is conveyed to the sensory portion and then conveyed to the frontal lobe. Once the frontal lobe decides what to do, then it exercises the emotion of that limb that it wants based on the cortex area that it fires. So if I fire this area right here, it goes to the opposite arm and causes the contraction to take place. So if I tell my thumb to move, the portion of the brain that's responsible for my thumb motion is a frontal precentral gyrus, okay, that sends information to my thumb, which is right about here, and goes all the way to my thumb. Okay? And it goes contralateral side. Then you have the temporal auditory process area. The temporal auditory process area takes sensory information that's coming in from the ears and then begins to go to the Wernicke's area. The Wernicke area basically takes information that's coming in and translates for you. It can actually translate different languages. Okay? If you don't have prior exposure to a language, then you don't understand the language because Wernicke's area doesn't have the decoding sequence to understand what you're hearing. Okay? Now what's really interesting is that we have a universal language. Okay? If you take babies and put them together, they actually speak to each other. Okay? We think that's the case. We can't really absolutely prove it, but we do see that they have their independent language. If you take twins, they'll develop their own independent language with themselves. Okay? And we think that's the universal language that they start with. And that's without even parents around talking to them. They will develop their own independent speech. And they will talk to another kid from another country and basically speak to each other. So there's a universal base that we have. Unfortunately, because we separated into different communities, we actually developed individual languages, okay, which is kind of detrimental because now we can speak to each other. But originally we apparently had a single unitary language, which has gone away over time. Some people think it's actually a virus that was impregnated in adults that caused us to speak different languages at one point. An interesting concept that I read about a long time ago. Anyways, this Wernicke's area is what actually allows you to interpret all information that's coming in. Okay? And when that information is then conveyed to the frontal lobe, where then you can do something with it. Okay? So if you hear something, like somebody talking to you, say hello, and then it goes to the Broca's area, and you say hello. Okay? Without the Broca's area, you don't get it. If you don't have the Wernicke's area, you can still speak, but everything will be garbled because you don't even understand what you're saying. Okay? So Broca's area, you may actually speak, but you can't make any sense out of it. Okay? This is showing you how the complex formation of how the sensory information is coming in. Okay, it's modulated by the temporal lobe, and then goes to the Wernicke's area where it's actually modulated, and then the information is sent to the Broca's area where it then sends its motor impulses to be able to speak. And it shows you that there's a whole pathway set up. Nothing happens by accident in the brain. Everything has pathways, there's axons, everything is connected up into different little computer centers that work independently of each other, not independently of each other, they work together as a team to do the end effect. The parietal is a sensory process area. Okay, the most important part of this is the postcentral gyrus, of course. Okay, and then you have the occipital lobe, which is what actually processes the visual fields. Okay, now what's interesting about it is the occipital lobe is what sets up the brain to how it's configured. Okay, and if you want to think about it theologically, in the sense of point of why is the brain the way it is, why is it that when I move my right hand, okay, I'm actually using the contralateral side of my brain. Okay? When I move my left hand, the initiation firing point is coming from the right side of my brain. Now you ask yourself, why would it be set up that way? Why doesn't just the brain set it up where the motor is on the same side as the motor effect that it wants? It has to do with the visual fields, most likely. Okay? When you see the visual fields, okay, your eyes are like cameras. okay? But they're not cameras that are on a flat plane. They're on a curved plane. So everything that I see on this side, okay, from this globe, and this portion, the outer portion of this globe, is actually seeing the world on this side, okay? Now, the information that's on the inner side of this other globe is also seeing the other part of the world. And I'll show you these pictures in a minute, when it comes back towards the occipital lobe, everything that's coming from this world is actually coming over here to touch this portion of my brain, okay? Now, the reason that's important is, let's say I put my hand out, and when I put my hand out, I got a saber-toothed tiger that's right there that's going to take a chomp out of my arm, okay? If I had all the motor controls on the opposite side, it would take the brain a while to send the signal to the opposite side to tell me to retract my arm. But by being on the same side as the motor cortex, it immediately sends the occipital region. It tells the arm move back. It's much faster response time. Okay, so simply our brain is set up just because our visual fields are set up the way they are. I've always wondered what happens to people that are blind. Is their brain set up differently? Well, their motor strips change because they're actually blind. I've never been able to hear that argument from neurologists yet, but I'm going to decide to do that one of these days. Anyways, you got the next structure that connects up the hemispheres is the corpus callosum, which allows the coordination between hemispheres. This is this structure here. Now, the corpus callosum is very, very white. Why is it white? Because it's got myelinated fibers running back and forth through it. Okay? There's no nerve bodies sitting inside the corpus callosum. It's all myelinated fibers sending information from one hemisphere to the other and talking to it. So basically, you have two separate computers sitting in parallel, working with each other. Okay? So the cables connecting in between them is the corpus callosum. Okay? Pretty much like how Cray computers work in a very big network. They work together like that. Okay? Anyways, valleys and hills of the cortex. The hills are the gyri, the grooves are the sulci. Okay, the central sulcus by far is the most important structure. So it separates out the parietal from the frontal lobe. The fissures are also important. You have the longitudinal fissure, which divides the two hemispheres on the top. That's the longitudinal fissure on the top. And then you have your lateral fissure, which is over here, that separates out the temporal lobe from the frontal lobe. You can have functional classifications, which is originally done by by Brodmann. Brodmann basically first described the actual classification based on function of the brain, and that really helps us understand how the cortex worked. The diencephalon is the next portion of the brain we'll talk about. It's the reptilian brain, so the essential portion of it is classified by words containing thalamus. So anything that has its diencephalon contains the word thalamus. You have epithalamus, subthalamus, thalamus, and hypothalamus. Okay? The thalamus is a major integrating center for afferent information coming in. The only exception to that is olfaction. That's why olfaction is so potent, because potent, in a sense, it does not get modulated at all by the thalamus. Okay? If you've never known, if you don't understand that, you're going to understand when you get to clinical. There's certain smells that no matter what you do, you can't make it not affect you. Okay? So olfaction is a very potent stimulus directly to the brain. All the other afferent stimulus that are coming in, sensory, proprio, pain, temperature, all those things are going through, eventually reaches the thalamus first before it gets to the parietal region of the brain. Okay? Now the reason that is because you can actually modulate the system down. Okay? If I've got a saber-toothed running tiger behind me, and all the sensory inputs are coming back, hey, look, you're hurting, stop, hurting, stop, hurting, stop. That would be good. The saber-toothed tiger doesn't have me for lunch. Okay? So instead, the central nervous system says, hey, emotionally, you know what? I don't care if you're having pain, dude. It says, you better run, because otherwise you're going to get lunch. Okay? So they shut down the thalamus. Okay? So all that sensory input that's causing you severe pain, guess what? You don't feel any pain, because it never gets to your parietal region of your brain. Okay, so the thalamus is a very important center to shut down afferent information when it doesn't need to be sent, okay, which is going to be detrimental to your survival. So, and that's very important too for soldiers or people that are under high stress. The thalamus is one of those things that you can use to shut down information to make you be almost like superhuman and then do things that you would normally not be able to do. Okay? So the thalamus is all the sensory information, okay, coming back here, eventually goes to this. I call these the two potatoes in your head. The thalamus is like two little potatoes that are sitting one on each side. Okay? And that's what all the sensory information is coming in. The hypothalamus, on the other hand, is responsible for the maintenance of constant internal environment. So the hypothalamus is really important for autonomic nervous system control. It also is implemented for behavioral patterns. Okay? If you smell a steak, you immediately begin to salivate. Okay? You immediately feel like I'm hungry. Okay? Of course, if you're not a vegetarian. Okay? So not to going against anything vegetarian. Okay? But if you're a vegetarian, then on the other hand, your mouth would get dry, and you'd go like, stay away from me. Okay? So depending on your emotional content, in other words. Okay? So it's behavioral patterns. Visceral and somatic responses will also take place. Let's say if you're a runner, the hypothalamus, if you begin to think, okay, I'm going to go running at 2 o'clock, well, your body looks at the clock internally and says, well, at 1:30, my heart rate's going to begin to increase. Okay? So by the time you're actually almost out the door, your heart rate's bumped up by 20 points. Okay? You're peripherally a little bit more vasodilated. Your breathing is increased in ventilation. All those things are autonomic mechanisms that are already taking place without you even thinking about it. Okay? It's already setting up your body to run. Okay? You can have effectual responses, which is information that's coming in that can actually affect the hypothalamus as well. Hormone synthesis is critical for this area. Of course, it produces most of all the hormones that eventually lead to other hormonal releases at other end organs, which we'll talk about in endocrine. There's also sympathetic and parasympathetic activation that takes place here. Feeding, physical expression of emotion is also at the hypothalamic area. Sexual behavior, pleasure and punishment centers also located in the hypothalamus. And the level of arousal or wakefulness is also here at the hypothalamus. Now the basal ganglia is the next section. It's inside the cerebrum. It's a very complex structure that looks almost like a crown inside the brain. Okay, you can actually think about it that way. There are tracts that are actually nerve bundles that are actually what's called an internal capsule. It takes a tremendous amount of information, the sensory cortex to the basal ganglia. The basal ganglia then sends information to the motor cortex on how to best deal with the sensory information. Now the internal capsule connects up to many different things. Okay, shows you here how this is all very highly developed. Okay, see this is like a crown on somebody, the basal ganglia. Okay, now these structures are important for memory and allocation of sensory information to some allocation to a prior memory. Okay, in other words, what I'm trying to tell you is, let's say you've never seen a sailboat before. Okay, and you have no idea what a sailboat is. Okay, when you first see it, you don't even know what you're looking at. Your brain doesn't even know what to interpret as to what it is. Okay, it begins to make associations to it. Okay, it will say, okay, it looks like, if I had prior exposure to a boat, it looks like a boat. Okay, but it's a specialized kind of boat with big sails in it, which I've never seen before. Okay, so it doesn't really know what it is. Okay, so when you've never been exposed to something, okay, your memory will make up for the lack of understanding what you're looking at and put in something crazy that may be only associated to what your brain thinks at that time. So if you see, let's say, something coming at you that you've never seen before, and he's big, furry, and he's brown, and he's got big teeth, okay, and you think of bear, okay, that's a bear. Okay, it could be the abdominal snowman. Okay, it could be a yeti. It could be something completely different. It could be something similar to it. But the only thing you'll interpret it as is being a bear. Okay, so until you become accustomed to what you're looking at, then your memory will pattern and will develop something that your frontal lobe can then accept, and then you can actually process it based on that situation. That's what makes things very dangerous. When you have people like working over, they work with panda bears. Most Americans think panda bears are great bears. And they think pandas are cute and they're cuddly, and you know, ever since you're a kid, you thought of a panda bear as being cute and cuddly. Well, if you ever look at a panda bear in China, he's not with the zookeepers. He's behind a big metal fence with big bars. Okay? Because a panda bear is cute, he'll eat you for lunch. Okay? So if you don't have that memory allocation to that, you'll do something stupid and end up getting yourself hurt. Okay? Now, the basal ganglia, of course, is also the emotional center, the limbic control mechanisms as well, that helps regulate this memory and control mechanisms. Okay? It's composed of all these different structures. I don't want you to memorize all this, okay, because it's not really related to what we do completely. You just know that you have to know some of the basic structures of the brain. Okay? It is the limbic system composed of behavioral responses, emotion, smell. It also consolidates long-term memory and short-term memory. It just shows you how it's all internalized in here. The reason this internal structure is in here is because it takes the thalamus, which is right here, okay, and then the sensory information gets conveyed through this portion, and then you get the actual effect to the frontal lobe to be finally interpreted. So you have a lot of memory in this portion of the brain. That's why they say when you're dying, you have recall of memory. Some people say they see everything that happened in a rapid speed. Okay? And most likely that has to do with anoxia. And as anoxia is taking place, the cortex is losing its information inhibitors, and what you start seeing is firing of the inner portion of this basal ganglia area, okay, which gives you memory recall. It's emitted into your brain. That's why you may actually see a rapid occurrence of things that you've seen in the past. The basal ganglia system is the major cerebral nuclei are located here, which in other words, these are cell bodies. They interconnect the spinal cord, thalamus, the premotor cortex, the red nucleus, and reticular formation. This is an extremely important area in the sense that it's a modulator of information that gets conveyed one in and out. Now, if you didn't have modulation in the system, in other words, a down regulator, you would go absolutely crazy. Okay? Just the clothes on your back would drive you nuts. When you put your clothes on, the information, the sensory information is telling you that you have a shirt on. Okay? But after a while, your brain shuts it down and it doesn't bother you that you have a little bit of a small piece of cloth that's rubbing up against you and is causing a little bit of irritation. Okay? Your body doesn't mostly sense that. It's not aware of it until it starts really becoming uncomfortable. Okay? Other people actually have a situation where they have no modulation, and anything that touches them, which is called allodynia, causes severe pain. Okay? And we think that system is a failure of the basal ganglia system to suppress the afferent information. Okay? The function of this basal ganglia gives you the ability to fine motor control, and we don't understand totally how the full function takes place, but we know it's a very big integrator of all these different components of the brain. Without the basal ganglia, basically you're not going to do very well in life. The brainstem is where pretty much everything that you need for survival of the autonomics exist. Okay? It is really not responsible for thinking at all. You're not considered brain dead until your brainstem is dead. So the downside to that is that you're really not a human being anymore at that point. But you're considered still alive by technical terms. If you have a brainstem, that means your heart rate will stay stable. Your respirations should be adequate at that point, or at least suppressed, but you'll still try to breathe. But you really don't have any purposeful movement. You don't have any way of thinking at that point. You're completely isolated and just basically down to the reptilian portion of the brain. Okay? The brainstem is broken down into three parts. It's composed of the midbrain, pons, and the medulla oblongata. Okay? The other portion is sometimes considered part of the brainstem is the cerebellum, although I consider that a separate section most of the time because that's really controlling the fine motor control mechanisms of your body. The midbrain is a crossroad area. It contains cranial nerves 1, 2, 3, and 4. So there's 4 cranial nerves for every midbrain. Sorry, there's 4 cranial nerves for every portion of the actual brainstem. Okay? You have the corpus quadrigemina, what's called the superior colliculi, which is here. Okay? And the superior colliculi are involved in involuntary and involuntary visual motor movement. It makes sense because cranial nerve number 1 is what? Which one is it? Olfactory or optic? Olfactory, good. Okay. 2 is, okay, 3 is oculomotor. Okay. And 4 is trochlear. Okay. So 2, 3, and 4 are all I. Okay, which specifically 3 is what controls your lateral nystagmus motion. Okay, and 4. Okay, so when you have, the reason I'm teaching you this stuff is because when we give Diprivan, okay, which is an anesthetic, it's a liquid anesthetic that we deliver all the time. We know it goes to the portion of the brain that has the most vascular blood flow. And the area of the brain that has a lot of vascular blood flow is the cortex. So the cortex is where the medicine first binds and basically suppresses and starts making your ability to make emotional content and make good peripheral decisions to go away. So as soon as you start giving somebody low doses of Diprivan, the person will lose their ability to do complex mathematics. They won't be able to, tell you everything to be perfectly accurately. But you can actually have somebody who's awake, who's talking to you, and you can interrogate them and get all the information that you want out of them, and then they're still asleep. Okay, because they can't form any short memory. Okay? As you give them more Diprivan, you basically begin to affect the actual different portions of the brainstem. The first portion that you knock out is the midbrain. When you knock out the midbrain, you knock out the visual fields, in the sense that the eyes will close down and the person won't be able to see anymore. Okay? If you want to see if somebody is amnestic, okay, you tell them to open their eyes, and they will, okay, and you tell them to look at you. And when they look at you, they'll get what's called lateral nystagmus, which means instead of keeping their eyes straight and looking at you, their eyes will drift back and forth. Okay? That person's amnestic at that point. They can talk to you all day long, and they will not remember a thing. You can actually do a great anesthetic if you know that. You can yap with them the whole time. The surgeon will actually get irritated because like, why are you talking to this person so much? So you get them a little bit sleeper so they don't bother you anymore. But if you want to find out something about that person, you can find out really well that way. Okay. Now, the eye signs are indication that the midbrain's gone out. Okay. So the lateral nystagmus means that the midbrain's gone. Okay. You also have an area what's called the tegmentum, which has got the red nucleus, which is the major motor output center affected by the cerebellum. Okay? And then you also have substantia nigra, which is where synthesis of dopamine takes place. In other words, this is where Parkinson's disease is. So the midbrain is where Parkinson's disease processes are taking place. And then you have the cerebral peduncles, which are down here. Okay, peduncles are tracts, okay, which means that they have efferent fibers from cortical spinal tracts. So the trick is reading this is cortical spinal. That means cortex to spine. So these are efferent fibers. So there's the cerebral peduncles, which are back here, okay, are the ones responsible for taking the information out to the rest of the body from the top of the brain. Those are cortical spinal tracts. Okay. Now the pons area, which is in the middle, okay, the midbrain, the middle of the brainstem, has the next cranial nerves, which is 5, 6, 7, and 8. Okay, that's responsible for the ability to breathe. Okay, it's not the only one responsible because the medulla area is really controlling breathing. But we do know that if you start suppressing this area, you begin to slow down your breathing rate. Okay, but it does not eliminate it. It does not cause apnea at that point. Okay, so midbrain hitting the pons. It does not knock out stopping breathing at that point. Okay? But you start knocking out the next cranial nerves, 5, 6, 7, and 8. Okay? Now, when you get to the next portion, the lowest portion of the brain, which is called the medulla oblongata, is once you suppress that, you get some significant effects. Okay? Because you begin to affect one of the most important nerves of controlling the parasympathetics, which is the vagus nerve, which is cranial nerve number 10. Okay? The last nerve, which gives you the most trouble in life, which is 12, is what? Hypoglossus. Okay? Okay, which is what? It controls what? Tongue. Okay, it's the one that gets you most in trouble in life. Your tongue. Okay, talking too much. Okay, including myself. Okay? So, God gave you only one tongue for a good reason. Use it once. Use 2 eyes, use 2 ears, more so than use 1 tongue. Okay? Reflex activities exist in the medulla oblongata. When you knock this patient, if you give enough Diprivan, you will begin to suppress this area next. So when you give enough Diprovan, the first thing you'll see is that the person's heart rate will actually accelerate. Okay? Now the reason you're accelerating the heart rate is because you're knocking out cranial nerve number 10 at the medulla oblongata. So initially the heart rate increases with Diprovan. The other thing that will happen is respiration is controlled at the medulla oblongata. The reticular activating system is here, and that's also what actually is the pacemaker cells for the actual respiratory drive. So once you knock this out, the person will go apneic. Okay? And then you'll see what's called an apneustic breath. So right before the person is going to die from the Diprovan, they'll yawn. That's called the breath of death, okay? Or the last breath you take in before you die. Okay? Because if you don't support the airway at that point, guess what? The person will die. Okay? So you got to watch for that. Okay? That means you've overdosed the patient. You don't have to freak out. Just realize that if you didn't have a nasal cannula on, you've got about 35, 50 seconds before they desaturate. If you got nasal cannula on, you got about 3 to 4 minutes before they desaturate most of the time. Okay? So you got to support the airway, and you may have to mask them. Okay? Now, what ends up happening over time is the next level is that the sympathetics get knocked out by the Diprovan because it binds to the sympathetics in the brain, in the actual spinal cord, and then heart rate drops back down. That means that you really are deep under Diprovan. Okay? So if you're asked when should you put an LMA in somebody when the laryngeal reflexes are completely gone away, and the answer is when you get bradycardia again. So if you see an elevation in heart rate, you still have the sympathetics still intact in the larynx possibly, and you may actually get laryngospasm when you try to put the LMA. You've got to wait for the heart rate to begin to slow down again. That's when you put the LMA in. That way you avoid the coughing and the laryngospasm and all the other reflexes. Okay? Inside the brainstem is a reticular activating formation. This is composed of inside the pons area as well as portions of the midbrain, but mostly it's in the pons and medulla oblongata. It actually maintains your wakefulness. Okay? It does not require an upper cortex to wake you up. So when a tiger starts gnawing on your hand, the reticular activating system gets immediately activated by norepinephrine release and makes you wake up. Okay? Before your cortex even knows what's happened. Have you ever been in the bed and you're asleep and all of a sudden you're out of bed and you're wondering why the heck you're out of bed? Something got you out of bed, usually a very loud sound or somebody, trying to scare you, or somebody came into the room you didn't expect. The reticular activating system did that for you and woke you up. Okay? In combat situations, the reticular activation system is hyper accentuated. Okay? In combat situations, when you get massive releases of epinephrine due to the adrenal cortex, it actually begins to change the reticular formation and becomes actually hyper accentuated by that. Some people actually can actually hear the grass move. It's not a joke. People actually can do it. They actually can sense it. And people are sleeping halfway, and as soon as they hear any kind of movement, they're awake instantaneously. So it's a very different world that we live in. We go to bed and we worry about, is the window shut? Do we have any light coming in at us? And in different combat situations, those guys don't worry about it. All they're doing is trying to hear for something to change. The cerebellum is responsible for conscious and unconscious muscle synergy. It receives conscious and unconscious feedback. Okay? And that's really important if you're a gymnast. The cerebellum is one of those critical components of your brain that takes repetitive action, memorizes it, and integrates it as part of a microcomputer. Okay? So it figures out exactly what to do. So if you tell a gymnast and you ask them exactly how do you do it, the gymnast will look at you and they'll say very simply, I just do it. And you ask them, can you explain to me how to do it? And most of them can't. And it's not their fault. It's not they're trying to hide it from you because it's a big secret. It's because they don't really know. What's really controlling it is not their cortex. There's no way to actually understand what they're doing perfectly. Okay, it's done by the cerebellum. If you want to mess up a gymnast, tell him to think about his moves as he's trying to do it. He'll fall off the bar and kill himself almost, So versus if he doesn't, they're actually trained, don't think about it, just go up and do it. Don't think about it. Because if you think about it, what happens is the delay mechanism of having conscious thought to tell you where you put your foot at is too delayed versus the cerebellum can give the immediate feedback that's so fast that they can do it faster without having to understand what they're doing. So they go into these routines by repetitive action. Okay? How they get hurt is usually when they're not doing it in a repetitive action. When they're learning something new, that's when most of these athletes get hurt. Okay? It's the same thing when you're dancing with somebody. They tell you don't think about it. Your legs will move better than if you try to think about it. Okay? Same kind of reasoning. Okay? The other thing that's different about the cerebellum is it has ipsilateral control of the body, which means it's faster in controlling the individual components. Next level is spinal cord. The spinal cord lies within the vertebral canal and is protected by the vertebral column. It connects up the brain and the body. It connects the somatic, autonomic reflexes as well as the sensory information. It provides motor pattern control centers as well, which we call the alpha motor neurons. It modulates sensory and motor functions. It also, the critical test question is in the adults, you see at the end of the spinal cord ends usually at L1 and L2. Okay? Most of the time we write in the books is L1. So you want to stay away from that area. So you put a spinal at L2 or below. Okay? The end doesn't mean that there's no nerve ending beyond that. You have what's called the cauda equina. Okay? The conus medullaris is where the actual last portion of the spinal cord, and then it splits into these bundles of nerves called the cauda equina. The cauda is basically a tail. Okay? And equina is horse's tail. So when you take out the spinal cord out of somebody's back and look at it, okay, it looks like it's like a horse's tail. That's where the word comes from, cauda equina. Okay? It's all the nerve bundles that are coming out. They eventually go out to the L4, L3, and the sacral nerve roots going out to the different portions of the leg in the rectal areas. Okay, the spinal cord is broken down into 8 cervical nerves, which is kind of strange because there's only 7 cervical vertebrae. Okay, but you actually have 8 cervical nerves because you have to add the additional nerve from on top because it's not just below versus everything else is comparison to, there's 12 thoracic vertebrae, there's also 12 thoracic nerves. There's 5 lumbar, there's also 5 lumbar nerves. And there's 5 sacral nerves, and there's 5 sacral vertebrae. Okay? And then you have 1 coccygeal. Okay? The regions can be broken down into 3 components. Okay? You can break it down into the dorsal column right here. The dorsal column is a sensory input that's coming back from the world. Okay? The dorsal horn, it's also considered the posterior horn, it conveys sensory and pain fibers. Okay? Then you have the intermedial lateral gray area, which is the autonomics. Okay? And then you have the anterior portion of the horn here, and that's motor. Sorry this didn't slide over. And when you look at the slides, this should be over, and this one should be over. These are underneath, and sensory is under the dorsal horn. Okay? The white matter is the myelinated tract fibers. They're divided into columns. Okay? The posterior column, which is behind here, is a sensory. Then you have the anterior column, which is the motor that goes out. Okay? Sorry. Now the system is set up in 3 layers like I showed you before in pancakes. Okay? The first pancake, which is posterior, which unfortunately this is upside down, but this is the posterior or dorsal area of your back. Okay? So this is the first pancake. That's the sensory component. The middle pancake is the ventromedial layer, which is the intermediate layer, which is the autonomics. And then down here, the last pancake is the motor. Okay, so there's 3 different layers of the way the spinal cord is laid out. The sensory information that comes back eventually through the dorsal roots. Okay? The dorsal roots has not only afferents from motor, but also has afferents from sensory and afferents from sympathetics and parasympathetics. Okay, depending on which portion of the spinal cord you're looking at. Okay? If you're looking at the thoracolumbar area, it would be sympathetic. If you're looking at the sacral root area, it would be parasympathetic. Okay? The somatic nerve endings which are going out as efferent fibers, as well as the autonomic efferents, are going out through the ventral root. Okay? These are all outgoing or efferent fibers. Notice how eventually they all form into what? One nerve. Okay? So this stuff eventually forms into one nerve bundle. Okay, so afferents and efferents together form a nerve. Now there's 31 pairs of spinal nerves. Okay, names correlate with the vertebral level, which they exist C1 through C7 above the vertebra. Then you have mixed nerves. Okay, 12 pairs of cranial nerves are found. Okay, which we talked about previously. 3 of those are purely sensory, 5 are motor, and then you have 4 that are mixed. Okay, vagus is a mixed nerve. Okay, it contains both afferent and efferent information going in and out. Okay. Fascicles are basically fibers that are axons. Okay. Then you have the rami, okay, which are brachial plexus, which we'll talk about a little bit later on, which originate at C5 to T1. The brachial plexus controls the upper body, okay, the arms basically, that are located between C5 and T1. And then we'll talk very briefly about dermatomes, which is important for our job as well. The motor system is transferred from the brain to the muscles. Okay? The way that does that is it takes information from either originating from 2 areas. It originates from the cerebrum, from the precentral gyrus. The precentral gyrus has a homunculus layout with the legs being on the inside portion of the brain. And then we'll talk about how blood supply causes different strokes. You can have different, why the paralyzes one leg and versus paralyzes the arm. It's 2 different blood supplies that are supplying those areas. The middle meningeal artery provides the medial aspect of the brain, which is where the hand and face are at, and the anterior cerebral artery provides the middle portion, which is responsible for the leg control. Anyways, you have myelinated fibers leave for the muscle. Okay, what they do is they leave from the precentral gyrus all the way down to the alpha motor neuron, okay, in the spinal cord. So they travel all the way down via corticospinal tracts, okay, all the way down to eventually touch the alpha motor neuron, where it has it's a presynaptic nerve ending. It binds to that receptor via neurotransmitter release, and then the alpha motor neuron then fires and sends off electrical signal via axon down to the muscle where it releases acetylcholine and causes the muscle contraction. So between the the temporal lobe of the brain all the way down to the spinal cord is one. That's the upper motor neuron, and then the other one is the lower motor neuron that leads from the alpha motor neuron down to the leg. That's considered the lower motor neuron. Okay? The reason that's important is because you get different pathophysiologic circumstances that occur when you damage either the upper or lower motor neuron. Okay? Now the pyramidal system, the corticospinal tracts originate on the opposite side of the limb that they control. Okay? So the cerebrum is contralateral to the control mechanism. Okay? So when I cause this, my left side of my brain to fire, I basically cause my right leg to move. So it's contralateral. Okay? It's called, the pyramidal system is considered a contralateral system. Once it reaches in this area, it ductisates at the medullary area, okay, which means that's where the fibers actually switch from one side to the other. Okay? The reason it flips at the medullary area most likely is because what is controlling that limb on the ipsilateral side? The cerebellum. Okay? So when it flips to the other side, the cerebellum interacts at the medullary area, right next to that area, and interferes with the signal as it's going out to the alpha motor neuron. It modulates the effect. Okay? The substantia nigra, which is a little higher than that, it's up in the midbrain, also regulates the signal as well. So you have different things that are regulating that signal before it gets out to even to the alpha motor neuron. Okay? The spinal cord, once it gets the nerve signal there, okay, which is the upper motor neuron is what's sending it, which is the corticospinal tract, eventually binds to the alpha motor neuron, which is the lower motor neuron tract, which is called the anterior horn cells, then goes to the muscle itself. This is a nice picture showing the full visual of how this actually takes place. Now, when you go to if you decide to ever go to medical school, this is how we learn it. Okay. Now, I think this is way above what you guys need to know because it doesn't really help. You have to take a whole course on neuroanatomy for a semester which we don't have time to do that. Instead, I just want you to know the basics. Instead of memorizing like this, which is pretty difficult, I'd rather memorize this. This is a schematic. A schematic is better to learn when you're having to do some clinical work. If you want to go back to specifics, at least you can always go back to this picture. Okay? Okay, fine. If you want to be a neuroanatomist or a neurophysiologist, great. But if you want to do clinical work, you need to know this. Okay? To do clinical work, you know that motor has to originate from the frontal gyri. Okay? It sends the corticospinal tract going down. That's the upper motor neuron. And you can see that it's staying on the ipsilateral side of the brain until it decussates at the medullary oblongata. Okay? That's where it actually flips to the opposite side. And then it travels all the way down to the anterior horn cell, okay, which we call the alpha motor neuron, that then sends the signal out to the muscle. See, that's a schematic. You can all memorize that. And you should always have that in your brain like that. Okay? And the same thing I'm going to do with sensory. I'm going to just go in the reverse direction. Now, what happens when you have lesions in this? Upper motor neurons, the efferent pathways primarily relay information from the cerebrum to the brainstem or spinal cord and synapse via interneurons. The lower motor neurons usually have direct influence on the muscles, but their axons extend into the peripheral nervous system. Now, what happens when you have clinical presentation of injury? If you have upper motor neuron loss, okay, you get spastic paralysis. Why do you get spastic paralysis? Because your alpha motor neuron is still intact. So you still get some actual signal getting to the muscle. Because when you hit somebody in the muscle, it causes a reflex action that will cause accentuation of that alpha motor neuron to fire, and so you get spastic paralysis. So spasticity means that when you try to move that person's leg, they'll start vibrating their muscles very aggressively, called spasticity. Okay, so that's an upper motor neuron lesion. Okay? You don't see loss of muscle tone. Okay? The muscle doesn't atrophy because there's still motor, alpha motor neurons still getting to the muscle. Okay, you can see fasciculations and fibrillations don't necessarily are present because you still have an intact mechanism. You tend to get hyperreflexia because I guess the reflex arch is still intact and the Babinski reflex is still intact. Okay? On the other hand, if you damage the lower motor neuron tract, you basically damage the ability for the alpha motor neuron to connect up to the actual muscle, so you get flaccid paralysis. And when you start getting no nerve signal at all, the muscle basically atrophies and dies. So it gets significant atrophy. As the muscle begins to atrophy, it begins to form all over itself what we call neonatal receptors. So if you just touch the muscle a little bit, it starts fasciculating and fibrillating. Okay? It's because those neonatal receptors are highly sensitive to any stimulus. Okay? Because you have no reflex arc, you get hyporeflexia and you get absent Babinski's reflexes. The reflex arc, I'm going to go into this just for about another minute and then we'll stop here. Okay? It's composed of three parts. Okay? It's composed of an afferent information. This is things like a prepatellar tap. Okay? When somebody hits you with a hammer in your prepatellar area, it sends a sensory fiber information coming back to the spinal cord. That spinal cord information goes to an interneuron, which then sends the information to the efferent neuron, which is the alpha motor neuron, which then causes your muscle to contract and causes it to jump. Okay? This is this mechanism here. This is a prepatellar reflex. Okay, you tap it. It sends the stretch fiber to be activated. That stretch fiber goes back and causes it to cause the interneuron to connect up to the alpha motor neuron, which then sends the signal out to the muscle to contract. Now, why would you have this kind of system? What's the purpose of having this? Because you can actually have somebody running at you and walking at you and have no brain. Okay, what actually regulates your actual walking has nothing to do with your brain. It initiates it, but once you have somebody walking, these reflex arcs help maintain you walking. It makes your muscles contract properly. And there's actually a mechanism in the spinal cord that lets you run. Okay? Have you ever wondered why when a chicken, you cut off the head of a chicken, it'll still run? Okay, it does. Okay? Human beings also continue running even though they have their head blown off. They've had several reported cases of that in World War I and World War II, where people were coming at them running, and the troops would freak out because they'd shoot these people in the head and they would still keep running at them. Okay? And that's a pretty scary thought, because what they're doing is the spinal cord keeps firing, so it keeps working. So the person will keep running just like a chicken without its head on. Okay? That's all it has to do with reflex arcs. Okay? The other thing that's important about reflex arcs is that it also sends an interneuron signal to the opposite side. That interneuron signal that sends it to the opposite side makes you pull your leg back away from hitting a nail. Let's say you step on a nail, okay? If you were to pull your leg back away right away, you'd fall. Okay? So, but what happens with the interneuron is it sends a signal to the opposite side to cause extensors to contract. It stabilizes your leg while you pull the other leg away before you even think about it. Okay? So these reflex arcs protect you from a very tough environment. Okay? All right, we'll stop here. Any questions so far? Give you a 10-minute break and we'll start back up.